Dr. Andrew Lane. He's one of our hosts. He's from Stony Brook University Hospital, and he's going to provide us with an introduction to APS-1. So I'd like to welcome Dr. Lane.
Good morning, everybody. I'd first like to thank Dave and Sherry Seifert, Jennifer, and Todd and Heather Tallarico for inviting me to speak today. I'd like to tell you about Matt. I first met Matt at age 6, but his story really begins well before that. At age 4, Matt had photophobia. He saw an ophthalmologist. He was diagnosed with keratoconjunctivitis from Epstein-Barr virus. At age 5, he had tingling, cramps in his extremities. He saw a neurologist. Some labs were recommended, but these weren't obtained because his symptoms very quickly and spontaneously resolved. At age 6, he had a seizure while he was at kindergarten. And it's important to note that he was very healthy and feeling absolutely fine in between these events. When he came into the intensive care unit, we were called over to see him. One of my fellows, a very bright doctor, went over to see him and saw a young boy with hypocalcemia and noticed that he looked very tan. And on exam, indeed, there was hyperpigmentation. His lab showed a very low calcium level, a very elevated phosphate, and an undetectable intact PTH. So she called me over and said, Dr. Lane, I think we need to order cortisol. And the cortisol was indeed undetectable. His ACTH was very elevated, his plasmarenin activity was elevated, and he turned out to have 21-hydroxylase antibodies, which are anti-adrenal antibodies. So I said, I think we need to order genetic analysis of his autoimmune regulator gene, or AIR gene. This is a gene that's located on the long arm of chromosome 21, and Matt turned out to have a homozygous, or both copies of each chromosome had a 13 base pair deletion in exon 8. And this finding confirmed our clinical diagnosis of autoimmune polyglandular syndrome type 1, or APS-1. This is sometimes referred to in other parts of the world as autoimmune polyendochronopathy, candidiasis, ectodermal dysplasia, or APSED syndrome. This condition was first reported in the modern medical literature in 1929 by Thorpe and Handley at the Children's Hospital of Philadelphia. They described a young child with chronic tetany and chronic myceal stomatitis, which is oral candidiasis. This child also had chronic diarrhea and had tooth enamel problems and many other problems. Since then, it's been recognized worldwide, but depending on where you are in the world, the prevalence varies quite a bit. So for example, amongst the Persian Jews, the prevalence is 1 in 9,000, reasonably common. In Japan, by contrast, 1 in 10 million by some estimates. Even in parts of the world that are perhaps more proximal in geographic locations, such as Norway and Finland, there can be a difference in prevalence. Although, as we'll touch upon later and other people in the audience will expand upon, there's now thought to be a non-classic variety which is actually quite common, perhaps as much as 1 in 1,000. In the United States, the prevalence, I think, is not really well understood. Perhaps Dr. Lionakis will elaborate on a current understanding of this. I've seen estimates anywhere from 1 in 200,000 to 1 in 2 million, but not a common condition, as you all know. So what constitutes autoimmune polyglandular syndrome type 1? Well, classically, individuals have to have 2 of the following 3 cardinal manifestations: chronic mucocutaneous candidiasis and or hypoparathyroidism and or adrenal insufficiency. Often individuals have other organs affected, such as the ovaries with ovarian failure, ectodermal dysplasia, vitiligo, keratoconjunctivitis, asplenia, hypothyroidism. This is a photograph that my colleague, Dr. Wilson, provided to me of a patient he saw many years ago. This is a young woman. I believe she was in her 20s at this point, and you can see she has symptoms that are attributable to her ovarian failure, the Addison's disease, alopecia, et cetera. So what are the first manifestations of this condition, and when do they typically present? This is a question that has been, I think, answered much more fully with a couple of papers that were reported in the past year from authors that are in our audience. So the group from Bergen and Oslo in Norway and Uppsala in Sweden reviewed 52 APS-1 registry patients from 34 families, followed over a long time, over 20 years, and each line on this little diagram is an individual patient. And you can see that primary adrenal insufficiency, or Addison's disease, is the first manifestation in about a third of patients. It occurs at a wide variety of ages, sometimes in young children, but more typically in mid-childhood, and sometimes not until 20s or 30s or even later than that. Hypoparathyroidism is the first manifestation in about another third, and this tends to occur a little bit younger, so in sort of more of the mid-childhood range, but again, there's a wide range of ages. And chronic mucocutaneous candidiasis, again, in a little bit less than a third, this tends to occur at much younger ages, and one of the things that we'd like to kind of discuss today is how can we arrive at a diagnosis of APS-1 earlier, quicker than has traditionally occurred. And one of the challenges that we face are things such as candidiasis may be attributed to factors other than being APS-1. So, for example, many young girls might have vaginal monoileitis or vaginal candidiasis, and it might be attributed to poor hygiene by the physician or the parent or some other cause, as opposed to being recognized as part of perhaps something larger. Keratoconjunctivitis, alopecia, vitiligo, pernicious anemia, hypothyroidism, sometimes other presenting symptoms, but not typically. So what about Matt? His subsequent course has been notable for admissions for hypocalcemia, hypertension. He's had acute disseminated encephalomyelitis, vitiligo, dyspepsia. He's had admissions for adrenal crises, gastrointestinal candidiasis, and Sjogren's-like syndrome. So Matt has manifested not only the classical symptoms. This is a piece of a diagram from Dr. Lionakis' recent report. Matt has had the typical classical features, hypoparathyroidism, adrenal insufficiency, and the candidiasis that we typically see. But he's also had some of the symptoms that are being recognized as being perhaps enriched or more common in the US population. These include intestinal dysfunction, hives, gastroenteritis, hepatitis, the Sjogren's syndrome, and pneumonitis. And this is perhaps a bit different from the experience of other populations around the globe. The US population, for a variety of reasons, perhaps having more of these particular features, and I'm sure Dr. Lionakis will, again, elaborate on this in more detail. I'd like to discuss just a few of the cardinal manifestations and describe those a little bit. So adrenal insufficiency, the median age of presentation in the US is 8 years of age. It eventually occurs in about 70 to 90% of all patients. The destruction of the cortex can be very slow, and either cortisol or aldosterone deficiency can occur first, and sometimes they can occur up to 20 years apart. Humans normally secrete cortisol in sort of a diurnal pattern, so this is characterized by very low levels overnight from midnight to about 3 or 4 in the morning when the cortisol levels start rising up, reaching a peak around 8 or 9 in the morning around breakfast time, and then slowly drifting down over the course of the day with peaks around lunch and dinner time. And one of the challenges that all of our families face with replacing the adrenal glucocorticoids is that it's very difficult to mimic the normal physiologic pattern with the currently available treatment modalities we have. So if an individual is given too much hydrocortisone or prednisone or other glucocorticoids, they might have linear growth failure. This would be the height dropping off and the weight increasing on a height and weight curve. If they're given insufficient glucocorticoids, they might have fatigue. And of course, if an individual has a very stressful illness, such as a broken bone or high fever, or if they have a vomiting illness where they can't take their oral medications, they have to be given injectable or parenteral life-saving stress doses. So one of the reasons that we have trouble with mimicking the physiologic pattern is that hydrocortisone has a very short plasma half-life and the levels drop off relatively quickly. And so you can see in the slide here circled in red, there are times during the day during which individuals have very, very low or undetectable cortisol levels, including parts of the afternoon or evening. One of the things that people have been looking at to try to address this is perhaps adapting insulin pumps to deliver hydrocortisone in a physiologic pattern. These pumps are programmable, and we use our people with diabetes as sort of a model to look at this. So a few years ago, a study was published, a multi-center, randomized, double-blind, placebo-controlled trial, a very good study was published. Unfortunately, it didn't show any improvement in subjective health status in the individuals who were receiving the hydrocortisone by pump. Problems with the study, the number of subjects was relatively low, and the baseline health scores, which was one of the outcome measures, was relatively high to begin with. But that's sort of maybe dampened enthusiasm a little bit. One of the other concerns, based on our experience with patients with type 1 diabetes, is what happens if the catheter kinks and the hydrocortisone is not delivered, or there's some other type of pump failure in our diabetics, their blood sugar goes up very quickly. In someone who's relying on their glucocorticoids, symptoms might not be as noticeable as quickly. So one of the other strategies people are looking at are modified release oral hydrocortisones. There's a couple that are in development, a dual release oral hydrocortisone with an immediate release outer coating over an extended release core. There's also one called Chronocort that tries to replicate the overnight rise in cortisol. That's actually in phase 3 trials. So we're hopeful that these approaches can help improve our treatment with hydrocortisone or glucocorticoid replacement. What about hypoparathyroidism? Well, the median age of presentation in the United States is about 5 years of age. It's eventually found in many patients, and it often presents as a hypocalcemic seizure, but sometimes it presents, again, insidiously, such as a history of croup, which is really just laryngospasm, similar to sort of the carpopedal hand or limbs cramping that you might experience from a low calcium level. How do we treat hypoparathyroidism? Well, calcitriol or 1,25-dihydroxyvitamin D is a mainstay of treatment along with regular vitamin D and, of course, calcium orally. The problem is all of these treatments can predispose an individual to hypercalciuria and kidney stones. So one of the things that people have looked at is, can we possibly use a portion of the parathyroid hormone, the 1 through 34 amino acids of the whole 84 polypeptide molecule. This is known as teriparatide or Forteo. Many of you in the room have probably used this. Problems with this particular medication is that it's very expensive. It's difficult to get insurance approval for this. There's perhaps a risk for osteosarcoma, although that's really more in rodents than in humans, but there is a black box warning by the FDA regarding this medication, so that gives physicians pause. Recent data presented by Dr. Gaffney at the Endocrine Society meeting this year demonstrated that the use of teriparatide is perhaps associated with decreased urinary citrate, which is a setup for kidney stones, and then long-term use may be associated with persistently increased bone turnover, and in young people that may not be desirable. People have looked at whether or not teriparatide can be used in a pump also. A 3-month crossover trial comparing recombinant PTH 134 by pump versus twice-a-day injections didn't show any differences in urinary calcium. So again, people are looking for additional medications that could be beneficial. These include calcilytic drugs that are currently under development. These are basically molecules that will attach to the receptor that sits on the outside of kidney cells and parathyroid cells, and this class of medication may help prevent kidney stones. So we're really hopeful that calcilytic drugs will be beneficial to our patients. Recently on the market is Natpara, which we already heard a little bit about this morning, and again, please stop by the tables outside. This is a very new medication, and so there's not a lot of data yet, but we're hopeful that perhaps it can ameliorate some of the concerns that have been raised with the shortened version of recombinant PTH. What about candidiasis? So the median age of presentation in the United States is a year of age. Again, it occurs in most patients by their mid-20s. And how do we treat this? Well, oral and topical antifungals are the mainstay. Sometimes individuals will run into problems with recalcitrant candidiasis that just doesn't respond to the typical oral treatments. So oftentimes we'll use amphotericin, but this can be very damaging to the kidneys. It's nephrotoxic. So one of the strategies people are looking at is maybe coming up with a medication that blocks the little sticky proteins that hang down from the candida organism and allow it to attach to the mucosal surfaces. And this might hold some promise as a useful treatment for candida in individuals. So what causes autoimmune polyglandular syndrome type 1? Well, the immune system can be looked at as kind of two big arms. One is innate immunity, the other is adaptive immunity, and they each have their own cell types. Innate immunity is a very ancient system. It's in all plants and all animals, and it provides an immediate defense against infection. So it includes cytokines, little proteins that float around in the circulation, the complement system, another set of proteins that float around, white blood cells. And this arm of the system will activate the other arm, the adaptive arm, but it doesn't provide any long-lasting or protective immunity. So people have evolved, or mammals have evolved, the adaptive immune arm, and this basically creates an immunologic memory. It's very highly specific to particular pathogens, and it allows us to have a very enhanced response. If we see an organism once, the second time it comes around, we have a very enhanced response. But in order for people to have this particular system, we have to be able to distinguish self from non-self or invader. And how do we do that? Well, there's an organ in our body, the thymus, which can be thought of as sort of the kindergarten of the immune system. It's where all the cells learn how to get along and play nice. And this is an organ that's relatively large in young children. It's in the chest. And by the time a child is older, it's shrunk down and nearly disappeared. And within the thymus, the air gene is expressed in a particular type of cell, the MTEC cell, or medullary thymic epithelial cell. And when the air protein is made and expressed, in turn, it induces or causes the expression or production of other proteins or peptides that are markers of self. These are the tissue-restricted antigens. And this is a photomicrograph of an MTEC cell expressing the air protein that's going to go on and do its job. So if we have an immature MTEC cell, the air gene is expressed, you have a mature MTEC cell. So the mature MTEC cell will express the self-antigens, they move out to the surface of the cell, and then an immature T cell with an autoreactive antigen receptor will come and bind to that MTEC cell, it'll recognize the self-protein, and it basically undergoes apoptosis or self-destruction, it's removed from the circulation. A T cell that has antigen receptor to non-self stays in the circulation, and it's available to attach to pathogens that come in and activate the immune system so that pathogens are destroyed. In APS1, each allele or copy of the air gene either has a mutation or a deletion so that the air is non-functional and the mature MTEC cell doesn't express these self-antigens. So the immature T cells that come along with those receptors, they stay in the circulation, and later on in life, they can migrate to a tissue that has that self-antigen and initiate the destructive process of that tissue or that organ. So I talked a lot about T cells. There's also another type of cell, the B cell, which produces autoantibodies in autoimmune polyglandular syndrome. These autoantibodies are another circulating layer of the immune system that can attach to pathogens and activate the system. There was some data from one of the APS patient collaborative groups. This was in Estonia and Poland, Germany, and England. And they looked at 81 different patients. Each patient had more than 100 different autoantibodies against a variety of different proteins, and collectively, the antibodies were raised over almost 4,000 different proteins. So it's thought that many, many individuals have multiple different autoantibodies. I see Dr. Campy shaking his head there, so perhaps if I misrepresent this a bit, you can elaborate on this further. But I think the point is there are lots of different autoantibodies out there. And one of the questions that's been kind of an interesting question mark in APS1 is why is the incidence of type 1 diabetes so low? So it does occur, but it's not one of the more common conditions. And despite that, the antibodies that we typically look for in our new onset type 1 diabetic patients can be found in APS1 patients. So that other little piece of the immune system I mentioned, the cytokine system, basically is important for allowing disease to progress. And so if an individual might be predisposed to develop develop multiple sclerosis or psoriasis or type 1 diabetes, some of these cytokines that are important for allowing progression of this condition, such as cytokine IL-17 in MS or cytokine Th17 in psoriasis or interferon alpha in type 1 diabetes, turns out there are antibodies against these particular cytokines, and so it's thought that perhaps the presence of these antibodies taking these cytokines out of the circulation or reducing their effectiveness perhaps can ameliorate some of these conditions that aren't so common in APS1. But there certainly is a lot to learn more about this. And of course, some people have speculated, could this be the basis for developing an injectable therapeutic anti-diabetes antibody? So with our current knowledge of the clinical course, the genetics, the immune system, how can we make a diagnosis sooner? And certainly individual components of the disease are recognized, but the broader syndrome often goes unrecognized. I'll just tell you a little anecdote I recall as a resident seeing a patient who was about 6 years old, and he turned out to have Addison's disease. Every morning he would go out to the bus stop, he would vomit, get on the bus, go to school, come home, next day, same thing. And this went on for quite a while, and his mom attributed this to nerves. And it turned out his emesis was the nausea that is one of the symptoms that you can see with Addison's disease. So that's a good example of how patients or parents or even physicians can attribute a symptom to something that is unrelated. In the Norwegian cohort, 7 of 52 patients had passed away undiagnosed in childhood, and the diagnosis was made on autopsy. So one of the hopes in this day and age of informatics is that perhaps with improved clinical acumen plus electronic medical records that are storing vast amounts of data, and computerized prospecting or algorithmic sifting through the data can perhaps be a way that symptom clusters can be recognized quicker and people can be brought to attention much sooner. Another interesting aspect is that sometimes, this has been reported relatively recently from a couple different groups, but conditions that are thought to be isolated, so just one specific disease component and not part of a broader picture, such as isolated hypoparathyroidism, in fact, may be due to mutations in the AIR gene. And some of these mutations may be just a little bit milder mutation. It raises the autoimmune predisposition just over a threshold that might be sufficient for certain organs to be affected, like the parathyroid gland, but maybe not other organs. Or it's thought that perhaps there are environmental triggers out there that interact with a particular mutation and cause just a single endocrine or non-endocrine organ to be affected. Similarly, for a long time it was thought that you had to have 2 abnormal copies of the AIR gene to manifest APS1, but it turns out people can have a single mutant copy of a AIR gene and manifest APS1. So something called a dominant negative mutation, you have the abnormal protein with the good protein, they maybe interact somehow and they kind of bring the whole level down just under that level of threshold of expression of AIR gene to get some autoimmunity. People with these types of mutations tend to have a later disease onset and a milder phenotype or milder manifestations. Dr. Lionakis' group's data shows that things such as enamel hypoplasia, intestinal dysfunction, and urticaria in hives not only are kind of more prevalent in the US population, but they occur very young. And in fact, Matt had hives at age 2 and again at age 9, and this was probably a first manifestation. Kids get hives for all kinds of reasons, viruses, they get into something, some kind of food allergen. So that's a sort of symptom that can be written off as not part of APS1. So I think it's really incumbent upon us as physicians and advocates to really try to maybe expand the physicians that we're trying to educate about APS1 to include allergists, ophthalmologists, dermatologists, gastroenterologists, dentists, pulmonologists, and other people to kind of maybe think about their individual problem that they're helping to address may be part of a larger constellation. Interestingly, there are no abnormalities whatsoever in the AIR gene in about 8 to 10% of APS1 patients. So if you look at the Norwegian population, hepatitis tends to be relatively rare and hypothyroidism is common. Conversely, in Sardinia, hypothyroidism is rare and hepatitis is common. And if you look in the population of Persian Jews, candidiasis tends to be a rare. So why is it that there's such a wide difference in manifestations of this condition. And it turns out there are probably lots of other genes that are involved in regulating air, or interacting with air. They're environmental. It's known, for example, that estrogen is a factor that can actually turn down the expression of the air protein. And it's speculated that perhaps one of the reasons women may be more predisposed to autoimmune disorders is that the expression of air is being downregulated. So there's a lot that we have to learn. Most of you probably know that John F. Kennedy had Addison's disease, and he once said, "The greater our knowledge increases, the more our ignorance unfolds." And while I would agree that that's true for APS1, I would add the corollary that every little bit of support and knowledge that each one of us in the room and all our friends and relatives can provide has a tremendous impact on the lives of those we love with APS1. Thank you very much.